The difficulty is balancing side effect profile and the benefit from the medication. So typically most anticonvulsants like gabapentin, for example, Neurontin, will be sedating. And so it may be an opportunity if the patient says, look, I can't sleep at night. I have horrible ability to sleep, and it's because I have this hot liquid magma pouring out of my leg because I have this terrible sciatica. It may be best to dose the gabapentin in the evening. Then secondarily, a more stimulating medication like a S-serotonin norepinephrine reuptake inhibitor like duloxetine may be provided in the morning. Both of them aren't opioids, and both of them are prescribed at doses lower than what would be expected. We call that rational polypharmacy, where either medication is prescribed at doses that are lower than what we expect, but still achieve an analgesic benefit with less side effect. I think typically the argument is currently yes, that we're kind of in a position where to think that way, to pivot and to treat pain with a rational approach that way, maybe perhaps with 1, 2, or 3 agents all at lower doses, but achieving success with less side effect. Probably true. But on the backdrop, we also know that there isn't enough pain specialists in the country to treat everybody. And even with the data from the Institute of Medicine, we know we have millions of people that would be in need of something like this. So part of what we spearheaded here at UC Davis is the suggestion of teaching people how to fish and actually training our current workforce. And we have a telementoring program where we actually take internists, nurse practitioners, and others in the circle of healthcare, and walk them through a 2-year or longer curriculum, and actually teach them each of these nuances about pain. That way, they can feel comfortable in treating these patients. Sadly, no. But is the impetus and the energy and enthusiasm there to change? Yes. And I think at no better time than now. Here at UC Davis, we're looking at trying to influence our current curriculum in the medical school. I think it's really ripe, fertile area in terms of the education for every medical school in the country to endeavor upon educating about pain management. In my experience, most people get 1 lecture, maybe a half a lecture in 4 years about what pain is. And most often, when they learn how to prescribe opioids, they do so as an intern or maybe a 3rd or 4th year medical student, and their first prescription is on the job without really case-based scenarios. So it's unfortunate, but we're getting there. We're in a situation in the United States where not only do we have an obesity crisis, but our sedentary behavior. Pain is also an influence of what we have as an investment. And how do we, as practitioners, work to motivate our patients and bring that enthusiasm back into their life to allow them to keep moving or to start moving, and to do so in a way that is healthy. So it really is a wellness approach, and that's a tough conversation. I would probably say that the reason why wellness wasn't bottled and canned and is flying off the shelf is because it's hard, it's tough to offer. And that's what I find difficult, but at the same time, probably the best part of my job, because the challenge of trying to motivate someone to become well with certainly a chronic illness over time brings the most satisfaction when someone says, it wasn't just a single injection that provided me relief for a number of months. In fact, I lost 70 pounds. I feel better. I sleep better. My obstructive sleep apnea has improved. My diabetes is in check because I lost weight. And by the way, my back pain's better. What I'd like to see is every year we have a training program here where we have fellows that have trained in their primary discipline, whether it be neurology, physiatry, anesthesiology, or any of the other specialties that can then transition into pain. I think what would be very interesting would be pain becoming its own primary discipline. I think it certainly has deserved the notoriety that it needs. The attention's there. It's certainly at this point a very interesting proposition. I think that where I see my career going is I focused on cancer-related pain. And we're at a point also in the United States of, I guess you could say, restructuring the thought process of how we deliver care. The fee-for-service model is really been tried and hasn't been as effective as what we would like in the outcomes. So the push is for this wellness strategy to offer patient-centered, value-based care. So how do we take all the tools for pain and offer them to patients that are struggling with cancer at diagnosis, but then take them through a continuum of care so that you're measured over the continuum of the patient's care? I'd like to see that really become a part of the current framework. It's just at its infantile stages now for physicians to be measured not on just snapshots of time, but really epochs of time and how we do. So I'm looking forward to that type of process.